So I'll make it a little bit interesting with having case scenarios. So I'll skip all these basic things, which I think all the. So basically the management is non-surgical, minimally invasive, and surgical. I think non-surgical. I think Dr. Quresh Mashkati has many very extensively told. So we'll be talking about minimally invasive options and then invasive options. In minimally invasive options, it is CXL, then it is ICRS, that is you can use rings, you can use ICRX with C3R, and you can use KS, and you can use like lasers like PTK and PRK C3Rs, all these things can be used. So coming to the surgical options, as these are the options other than a regular C3R. We can do a topo guided PRK, PTK, CXL with phakic IOLs, Bowman's membrane transplantation, DALK, penetrating keratoplasty, then microkeratome or femtoasteroidal lamellar keratoplasty and tuck-in keratoplasties. So why the newer treatments is that the newer treatments are now aimed at earlier stage of the disease, prevent morbidity associated with the disease, and also prelude the need for more invasive disease. So we do all these to improve the vision as well as to avoid to prevent them from going into the other stages. So case 1, when the patient comes, you have diagnosed keratoconus and all these things, and patient vision is improving to 6.6, and your topography shows there is a posterior elevation, cornea is thin, and this is the other eye where you can see the corneal thinning is there. So you can see that there is a posterior elevation here. So this is a frank keratoconus patient whose vision has improved very well. So when it has improved very well, just go ahead with a plain C3R. His vision is good. Just stabilize his vision. That's it. No more thinking about it. Case 2. When you see the right eye is 660, 2.5 and 618. And when the corneal thickness is good, around 480, 490, and it's a more of a central cone. So differentiate this because there are many procedures which I'll be explaining. So this is the second regular, when there is vision is improving, wherever the cone is, if the vision is good, do C3R. If the cone is in the center, and as I showed you, if vision is 6, it's not improving beyond 618 or 69, and is having a good amount of sphere rather than a cylinder and more of a central cone. You can see that the right eye can be treated as a PRK C3R, whereas the left eye, it is decentered. So just think about a central cone. When there is a central cone, you can go for the wavefront guided PRK C3R. So when you do a wavefront guided, you can see in the left side the same map after treatment. You can see there's a very good difference. The correction here is actually, you can see the difference. We do not do a full correction. For example, it's a 2.5. You do only half, 1.25 you do, because C3R is going to flatten and some patients might get plus. So before we used to correct minus 2.5, then the patient ended up in plus 1, +2. So our experience is that you only correct half the power. 2.5, 1.25 or 1.5 you correct, and you can see that over a period of time the patient improves to 6. Not everybody improves to 6.6, 6.9 something, but their uncorrected visual acuity improves from 660, they improve to 624 or 6.9, it improves. It is not about getting 6.6 in these patients. This is not a refractive surgery. When you do a aberrometer, these patients usually have a lot of aberration, so the wavefront guided takes care of the aberrations. So exclusion is in these patients because PRK you have to be very, very careful. Severe advanced keratoconus, corneal thickness less than 450, don't venture. Eccentric cones, previous refractive surgeries, and any hyperopic shift means that when there is a decentered cone, if you do a PRK C3R, the central cornea will become hyperopic and the peripheral cornea might become normal. So don't touch these cases, and unrealistic expectations. Tell the patient this is not a refractive surgery. We are helping you to be without glasses. Case 3, this is I've come to a decentered cone. You see there is a decentered cone, 618 improving to 6.9. You can go ahead with a plain C3R. If the patient insists on vision improvement, you can do the procedure. And this again you can see here, there's a more of a asymmetric cone down, vision 660 improving to 6.9. So these cases, what we can do, there are options. You can go with C3R, you can do a KS, you can do a customized C3R, or you can do a PTK C3R. So in these patients, again, when the corneal thickness is good, around 480, 490, we do something known as TREC, topo guided removal of epithelium, which is known as trans PRK. TREC is a combination of PTK and topo guided PRK, where around 50 microns we assume that the epithelium is 50 microns. But generally, what I do is I have an epithelial map. I see if the epithelium is 40, 45, usually, at the area of the cone, the epithelium is the thinner. So you just see, and according to that, you can say. So they say in a total ablation of cornea, around 70 microns you can go. 50 is epithelium and 20 is the stroma. So that you can vary. I usually don't go to 70, I do around 60, 65. So the concept here is when you do the laser, the epithelium is thinner in that area and the stroma also is exposed in that area at around 45-50 microns. So when you do it, there is smoothening of the surface. Here we are not correcting anything. We are just making the cone flat, and by doing that, the vision improves. So how we do that is we measure the cone here. This is the eccentric cone. We exactly measure this area. So it is almost like a very customized treatment. And we take the long axis, then we measure the short axis. So this is transferred into the whatever markings like 4.1, 3.1, whatever the long axis, and the center of the cone is marked. And you can see the center of the cone and is exported to the Schwinn data, the machine, to the laser. So it is exported. Once it is exported, then in the laser machine, we can exactly center. You can see that we enter all the parameters into this. And you can see that exactly what we wanted the cone, it treats the cone exactly that area. So 50 microns or 45 microns, you can compare and see exactly it shaves off the cone. And this is for patients who are above 470, 480, not below that. You can see that beautifully exactly that cone, the laser is done. So with different depths, like you can go with, you can see however you want, you can push the icon. So this is like after the PTK, you can see that there is a small laser there. So then we have to remove the epithelium and then go ahead with the regular. But I just wanted to show you how it does that area of this thing. So you can see that this is a pre-op map in the left side and right eye, and same comparison baseline at 2 months. Actually, the Gaussian curve means that irregular cornea becomes more flatter over a period of 3 months, and that's how the vision improves. And even in this, at 1 year, you see the irregular cornea becomes smooth. That's the concept. But the patient vision, you can see from 660 to 680, the patient improves from uncorrected 612 to 69. So this is, we have seen over a period of time, and it's definitely a patient who is above 480, 490. We should consider these things along with C3R. So case 4, again left eye, you can see 636 minus 2 cylinder, 618, and there is a mild inferior steepening. You can go with ICRS. So I'm not going to go too much deep because I don't do ICRS now. We do a lot of cares now, because this again the same area where there is a steepening, you make it flat and you can see and get very good results. These are some rings which are commercially available. So in cares, what I would do is, now this patient was using miniscleral lenses for so many years, became totally intolerant. 660 improved to 618 minus 1.5, 10 cylinder. So nowadays I do a 360 degree cares, means that corneal cares. You see that this patient have done a 360 degree cares, and you see from 660 to 618 he improved from 624 to 612. This is a patient who had both eyes problem. You see the right eye, such beautiful flattening of the cornea. You can never get in any laser because his thickness is 390, 400. Otherwise, you have to go for a DALK only. So I did a cares. You can see how beautifully the second map it flattens, and so much of flattening. K reading from 7, astigmatation from 7, it has gone to 4. So even these cases, 360 cares work. And in these type of cases, I do cares with CEDA because beautiful results. You see 5 by 60 improved to 618. You can see that I place the cone exactly. You can see I place the cone exactly in that area of steepening. You can see there. And from the patient improves very well from 5 by 60 to 624. And you can see that 624 with plus 2 with 612. See the amount of flattening in that area. You can see that area flattens so beautifully. This is another case. So this is, I showed you this, this was this side. The other one is on this side. You can see this, and the same from 660 minus 3 and 4 cylinder. The patient improves 624 with plus 12 with 6. So beautiful. Any side, left side, up, down, you can do a customized case in that portion and it does very well. And case 6, this is another case. It's for theoretical. Nowadays we don't do this. Means that a uniform steepening, 51, 51, everywhere uniform steepening with thin cornea and vision not improving. So we do a intrastromal lenticular insertion. Means that you make a pocket like a smile pocket and you insert a central lenticular tissue, and you can see that from 4 by 60, 6 improved to 618, not improving beyond that. But you can see the cornea, how much of from here it has become more uniform, and you can see that the intralenticular insertion creates good results. This I no more do, it's just for a completion sake. Cares gives beautiful results. And this is a post C3R. For example, a post C3R patient having -9, -8.5 improved to 612, very stable cone. Patient is having high myopic as well as cylinder. Go ahead with ICL. Very simple. Post do C3R, wait for 1 year for the vision to stabilize, go with ICL. And you can see here patient is almost 6.9, 6.6 post ICL, and ACD is very deep, so you don't need to bother about most of the times. And this is another case where left eye is 5 by 60, right eye is, this is the right eye, and left eye is gone like this. So right eye, you go ahead with a plain C3R because the vision has improved very well to 6.6. Left eye, you have to go for a DALK because the vision is not improving beyond 5. All these patients, you cannot do any other procedure like KRs or intrastromal ring inflammation. And you can see that this is right eye, C3R done, stabilized. Left eye, you can see post DALK, very beautiful flattening of the cornea, and vision from 5 by 60 going to 6.9 over a period of 1 year. I told you should not improve immediately. And this is the post-op pictures. And the other thing is acute eye drops. So most of the patients, we know that the DM tears. So even by mild rubbing, so you can do a compression suture with C3F8 in these cases. So you fill the gas two ways. You suture the superior. Nowadays we don't go full thickness. You do a partial thickness. The cornea flattens and then you give air. It sticks. If you go full thickness, it scars. So you can see here, this is day 1 or 2 post-op, you can see the edema. Once you know where the cleft is, suture the cleft, put air. Actually, the patient, we do this because otherwise 3 months or 4 months, the patient gets photophobia and it forms a very thin scar. And in very bad cases, when you see the cornea is really very bad, cornea is scarred like this, then penetrating keratoplasty is the only option. Vision 1 by 60 not improving. Go ahead with a penetrating keratoplasty. So as I told, we have to do first is that we have to catch the disease early, give visual rehabilitation and avoid DALK, PK and all. So final for the postgraduate, just finishing Bowman's layer transplantation. It's just that they know that the Bowman's layer is at fault in keratoconus. So they do a Bowman's membrane keratoplasty where from the peripheral cornea, they dissect like how we dissect like SACS, full cornea, and then they replace the same Bowman's membrane from the donor, dissect the layer, remove the epithelium from the donor, and then just do a dissection, lamellar dissection, peel off that, and then insert it into the stroma. How effective, I don't know, but I think a few people have done it and they have shown good results. So in the 10 commandments, I just wanted to brief it out that when the vision is 6.6, whatever I have talked, this is the brief thing. 6.6 plain C3R. If the vision is not improving to 6.6, 6.9, look at the thickness. If it is less than, if it is more than 450, go for PTK or PRK, go with vision correction. Less than 450, go for KRs if vision improvement is good. If vision improvement is not good, go for DALK or PK. Thank you.
Thanks, Adathan. Very nice talk, nice algorithmic approach. I think with all the case illustrations, it made it all the more interesting. I think you might want to add a word of caution that though you mentioned that C3R for those with 6.6 vision, C3R does have its flip sides, and therefore one should not think that when you're doing a C3R, it's a very straightforward, simple procedure and offer it irrationally. You would like to say something about that?
Because that's a valid point, because it's not about 6.6. Even Dr. Muscati sir was telling that it's like when you find that a patient is 16, 17 years, there is a progression and there is a cone and thickness is 470, 480, then I think it's tell the patient that progression will happen, and generally go ahead with the C3R. But if the thickness is good, around 510, 520, and you have not had any documented progression, you can always tell the patient, avoid eye rubbing. We'll see you after 3-4 months, if 6 months. If there is any change in cylindrical power, we can go ahead. Because C3R has its own, we have seen scarring, we have seen a lot of issues. So I think we actually titrate Geeta. Actually, it's like every patient, it's like we have a protocol. If the energy is around 3.7, we do. If it's 6.6, we do around 3.2. The soaking time is not 9 minutes, we do 7 minutes. So all these things.
Yes, so I think that is the point that
Yeah.
needs to come across,
Yeah.
that it's a very customized and
Customized.
tailored treatment where a lot of time goes into understanding the maps, understanding the patient profile needs, follow-ups before you take a decision. If it's someone who's going to disappear for a follow-up for the next couple
Yeah.
of years, you may still err on the side of doing a C3R, but someone who's there available to you for frequent follow-ups, you may want to document progression, because sometimes you can have vision threatening complications such as infection post C3R, and then long term we are now seeing patients coming back
Melt.
with central stromal
Melt, yeah.
and even impending perforation in these patients. So we still don't really know
What's
what it involves, and therefore we need to be extremely cautious when we take these
Yeah,
decisions.
two things. This is what she said is like, if the patient is not going to come for follow, because at 1 month they might have haze, so you might need to start them on cyclosporin for 2-3 months. If they do and they disappear, then they'll come back with scarring. So at 1 month you have to see if there is haze, start cyclosporin for 2 months. And second thing is, nowadays, even last month 2 patients I operated DALK, they were post C3R melt. You can't do anything, only the decimates is there. What you can do, you cannot do anything. So it's not as simple as to do. Everybody nowadays is, because it's like a non-surgical procedure,
Because
be
it's
very
a very
careful.
straightforward, simple procedure. We
Yeah.
believe that we can offer it and justify that it is the treatment of choice. 10 years, 15 years down the line, we are now seeing that these patients are coming back with complications. Therefore, we need to very responsibly take the decision about going ahead with C3R.
We have seen endothelial scarring, Swapna, but not as such edema, but we have seen endothelial scarring that has happened, vision dropping 1 line, 2 line. We have seen that, but not frank decompensation.
Not yet, yeah, no.
Sometimes scarring actually improves vision in the immediate post-operative. Initially, very long time. So some stromal scarring which actually fattens the cornea. Sometimes improves vision, but then later on,
If
Swapna,
progresses beyond what we want, then it kind of impairs.
the problem is sometimes these end up, when you see scarring, then flattening happens, and these guys goes to plus power. Then it's difficult to treat them.